There we go. All right. Remember, as I'm going, any problems, any questions, you're not getting it. Again, I don't mind being stopped. All right. So, sensory and neurological conditions. So, let's talk about something called otitis externa. And I think this is probably, let me see, what happened here? Excuse me, my computer just said something weird. I didn't like it. So let's go back. So, otitis externa, actually, this hurts more than otitis media. Otitis externa is the outside canal. It's called swimmer's ear. I'm a swimmer. I've had it, I can't tell you how many times. And it really hurts. It's pain and it's tenderness, but it's the outside. So, how do we treat these things? Well, number one, we look, make sure it's not the inside. There's nothing in there or anything, but eardrops, because it just, coats the outside. And usually it's an eardrops. Also, it has a little steroid in it, so it decreases inflammation and the pain goes away. Now, the one that really hurts is otitis media. And otitis media is when it goes inside the ear. Now, if we look at the oral pharynx cavity, everybody all the time has staph. It's just part of life. Now, usually it doesn't bother us, it's just there. But when it gets inside the middle ear, it causes that swelling, it causes pain. As I said last Thursday, I had an ear tube put in because of I was having some chronic otitis media and I had fluid in there. So the eustachian tubes weren't working. So the tube was working that way. So otitis media, what do we do with this? Well, you usually start, with that upper respiratory and all the mucus. We know it goes up eustachian tubes, goes up in there, gets the staph in there, and it creates this infection. So, what do you see in a kid? Well, sometimes you know the location because they're banging their head or they're banging on the crib, and they'll be crying and irritable. You don't always have an infection, a fever with otitis media, but you're going to hear them, by the way that they're acting. Now, I could not hear a thing out of my ear with this ear infection. I mean, that's how much it clogs it up. And then don't have that conductive hearing because it can't get in there to give you sound. So you're going to see a kid who's not responding to you. They're going to be talking louder, and you're going to see them, their pronunciation, hearing problems. If you can't hear, your speech is going to be affected. Think about not being able to hear the way you talk. So you know on my language, you know what you're talking about. And literally, that's what it would sound like. So you have this red, bulging eardrum, and we know that otitis media once, all right, 3 times, 3 months, or it continues, that's going to be called what we call a chronic. What do we give? Well, as I said, it's staph. Staph is a bacteria. Bacteria gets antibiotics. So broad spectrum, usually augmentin, amoxicillin. We'll start there and then work up if we need more. Remember eardrops, down and back for infants, up and back for children. And the eardrops are there usually for the steroid to decrease the swelling, and it helps. And we know, just like I just said, me, this old lady with ear infection, I needed to put a tube in, and I had it done in the doctor's office. When I was done with the tube, I got up. I was like dizzy. I had to hold on to the wall. And my husband, I had him waiting in the car for me. He came up and had to escort me to the car, and I was so grateful he was there. So hearing impairment's a big deal. As I said, it has all to do with speech. And if you're talking about children, they're just learning to talk. So hearing properly is very important. Now, if you're born due to whatever reason, and you can't hear, it's called congenital hearing loss, okay? Now, if it's like when you can't get the sound through, like I said, it was full of fluid, the sound couldn't travel, that's called conductive hearing loss, okay? Now, how do anybody, kids especially, talk and communicate? Well, if they can't hear, they can't pronunciate. So these children, number one, will learn either as if they're older and it's, this not just an acute, but a chronic, they'll do lip reading, they'll do sign language, braille as they get older, etc. They can write notes down for you. And we know with a kid, the way they act, what's going on. Sometimes, they're in pain. They're going to tell you, they're going to be crying. Or also you can have hearing aids that can sometimes give some of it. And then, we have those cochlear implants, which is, thank God it works, in some cases, but not all of them. And a lot of times we have these boards. Especially if you ever gone to a prescribed pediatric daycare and you have a child with hearing loss, they have these posters, or they can't speak and they could point to what they're wanting. Now, how do you talk to a kid who can't hear well? They're impaired. Well, number one, any kid, any age, get on their level. Don't ever stand above them because now you're threatening. Be face to face. Make sure you're looking at each other in the eye. When you talk, you're going to do short sentences. And don't do this over exaggerating because that doesn't work. Talk normally and don't yell because they can't hear, so don't yell. Now, visual stuff. We have nearsighted, farsighted. I'm a hyperopia, farsighted, because I cannot see in front of me. I need glasses. That's what these are for. Myopia is nearsighted. I can't see far. So it's opposite of what you think. You think nearsighted should be close. I don't know why they did that, but it's just the way it is. Now, other conditions. Strabismus. It's either your eyes, they can't work together. So this eye sees and this eye sees, and they're trying to look at the same thing, but your eyes are sort of moving. It really makes a difference when you're looking for depth perception. They don't have any because they don't work together. I mean, usually by about 6 months old, infants' eyes are working together, but with strabismus, they call it cross-eyed, but they just can't see. Now, amblyopia is when you have one eye that's crooked, up, down, sideways, doesn't matter. The muscle of the eye is weak. So how do you strengthen a muscle? Well, you exercise it, right? So how do you exercise a bad eye? Well, you cover the good one, and not on top of glasses, right on the eye, you put a patch. And it makes that bad eye work. And it will strengthen the muscles. And usually that's all it's needed. There's another thing called nystagmus, and that's when the eyes sort of jerk this way, or this way. And it's just a jerky eye movement. Now, strabismus amplopia, just like I said, usually it has to do with exercising the muscles. It's with patches, and rarely, but if nothing else works, of course, they'll need surgery to fix the muscle. One of the things that all kids get, because, they're always not washing hands, always touching their face, their mouth, always playing with other kids, hugging and, sharing germs, as I call it, swapping spit, as I call it. But it's called conjunctivitis. And these are your goopy eyes. They're pink, it's swollen, it's goopy, and it needs antibiotics, but eye drops, okay? So one of the things you got to be careful with, though, if you put an ointment in, let the kid know they're going to see blurry until that ointment dissolves, because they're going to freak out. Oh my God, I can't see, right? Could you imagine? I mean, even with adults, you should let them know, but especially children. Now, Sometimes they put a little bit of steroids in them. Again, remember, steroids make you that you can't fight infections. So you always are careful with steroids. Another thing, teaching these children how to wash their hands, important. And as a nurse, and this is in no book, but as a nurse, I will tell the parent, change their pillowcases every day. Because if you don't, what are you doing? They're putting their head down on the same dirty pillowcase. That's not in a book. That's just from Dr. Bogart. All right, retinoblastoma. Retinoblastoma is what we call a cat's eye, is what you see. Ever go outside at night and there's a light shining somewhere and you see an animal in the distance and you see the shiny white eyes? I mean, if you live in, by woods, you might see a deer or a fox or a bear. You see the shiny white eyes. Cats, dogs, all of them do it. Well, we call it cat's eye because, that's an animal, it's really not threatening. But any animal, you're going to see that white. When you have a suspicion of a retinoblastoma, you'll see a white eye. It's also called leukocoria. And that's the thing that makes us go and start looking for what's going on. I mean, you might have some loss of vision and other symptoms with it, but the thing that and I've only seen one in my career, it was an 8-month-old little girl. One eye, it was white. When you shine the light in, it was white. So how do we treat it? Well, it's cancer. So it's laser, try to get rid of it, chemo, radiation, but usually you have to go and remove the whole eye. And this is the one where post-operatively, they might get a fake eyeball to put in and grow up with. Now, one of the things about eyes, if you're doing an assessment and you're doing a check on the eyes, if the pupils are equal reactive, right? If you see an eye all of a sudden big, that pupil is big and black and it doesn't respond to light, this is an absolute neurological emergency. What it's actually telling you, there's pressure buildup in the brain. We usually see this more like with head injuries that we'll see. Now, altered state of consciousness. When does it happen? What do you see? Well, number one, if you have a blood pressure that's not good enough, you're not getting blood flow, you have a fall to 60 on your blood pressure, you're not getting blood and oxygen around. You're not going to have that. You're going to be restless. It's an altered state of consciousness. Another one is the CO2 getting too high. Again, there's not exchange of oxygen, carbon dioxide going on there. Again, low blood pressure, like I said, fever. We know we need fever. The heart's beating more, the body's working harder because that's what fevers do. You need more oxygen at that point. And if you don't have it, again, it could cause an altered state of consciousness. Of course, any drugs can cause it, especially any, sedative, opioids type things can cause it. So that could be the explanation. And we know after some seizures, like a grand mal seizure, we call it a postictal state, where afterwards they're confused, they're sleepy, they go to sleep. It's altered state of consciousness. And any increased intracranial pressure, that means the head is swelling, it's squishing stuff, and again, you're going to see it. So there's the names of your cranial nerves. You've learned it in health assessment, but again, looking at it again. Now, one of the things about children and giving them stuff for pain or fever, and aspirin is something that should not be given to children. There's only one diagnosis, and that's next week's lecture about cardiac, called Kawasaki disease. Besides that, if you ever hear a parent wanting to give aspirin to treat the fever, they should be taught absolutely not. it can cause hepatic failure, and these children could get extremely ill. It's called Ray syndrome, okay? Meningitis, what is it? It's an inflammation of the brain and the spinal cord. And with that, it could be viral or it could be bacterial. How do we know a kid might have meningitis? Well, you're going to see a fever. That's the big thing. But with that inflammation in the brain, you're going to have a bad headache and you're going to see them maybe start vomiting, nauseous. Of course, that stiff neck is classic meningitis, photophobia, sleeplessness, and then, really confused. Again, not getting enough oxygen to the brain causes that confusion. How do you determine if this child is viral or bacterial? It's only going to be a spinal tap. That spinal tap in a bacterial, you're going to see white liquid. In a viral, it's going to be clear. So what is that white liquid? It's your white blood cells. That's the bacteria. And it almost looks like milk. And you're like, oh, this is bacterial. We need to immediately get this kid on antibiotics. Another thing that we're going to be checking is Brzezinski sign and Koenig sign, and both of them, picking up the head or the knee and the head raises, these are all showing, again, just an assessment before we have all of the laboratory data saying, yeah, this meningitis. Now, in meningitis, they must be on droplet isolation for 24 hours and start the antibiotics. And 24 hours later, they could be taken off. That's considered now to be safe, to be out because they've had that antibiotic. And droplet isolation is usually one of those reverse flow rooms where that air can't go out into the other rooms and infect the children. With meningitis, number one, protect yourself. Always wear a mask, always wash your hands, absolutely. You're going to be doing neuro checks. You're going to be checking, all of their strength, making sure they're moving the way they should, intake, output. Their brains are really fragile. Sounds, lights all bother them. Monitoring their vital signs and giving the antibiotics if it is a bacterial meningitis. Now, seizures. What can cause a seizure in a child? Well, sometimes those strobe lights can cause it. Some kids and even adults are affected by that. Sometimes, you get scared and you jump, you're startled. Sometimes too much fluid. Sometimes just really bright lights can cause it, that can trigger it to happen. But look at all the things that can actually cause it. Infection, fever, epilepsy, drugs of all types, and low blood sugars. Low blood sugars, the brain needs sugar as part of their energy. So diagnosing seizures and the treatment. Well, we need to figure out what type of seizure is it. They'll first do, of course, a normal, just a x-ray of the head. Is there like a brain tumor? That would be the easiest. Oh, it's the brain tumor, and that's the cause. But sometimes they have to go and do the CAT scan, the MRI. They're going to do EEGs. And if you look at that kid, they smush those electrodes to the head. And sometimes they leave them there for over 24 hours to look at it. Always looking to see if there's anything out of whack in the lab. It could be potassium and sodium or chloride, all of the magnesium, all of those can cause if there is some sort of abnormality. And then what type of drug do we use? I mean, could it be something long-term? Do they need more than one? But they usually start out with one and they'll start adding on because the goal is to try to be the least amount of seizures a day. And there's some kids who still end up with seizures. So they have learned also diet. Diet is a big thing. Another, and this is not in the books, but something I saw on one of those documentaries I watched, using CBD on these children. I saw one about this couple lived in Florida, and the kid had seizures, couldn't control it. They had to move to Colorado in order to get the medicines he needed, and then that kid had no more seizures, maybe one every now and then. So it does work. As a parent, I would try anything to have my kid seizure free, for sure. So seizure precautions. Now, you know a kid has seizures, right? Make sure you keep those side rails up because you don't know when a seizure is coming. If you walk in and they're having a seizure, make sure that all the edges that are sharp are padded, and anything in the bed. You know, kids always have toys and everything in the bed. If they're having a seizure and they're rubbing all over it, it could cause, injury and lacerations. What if a kid is out swimming and is alone and has a seizure? They're going to go down and the seizure could last and they could drown because of it. So again, anytime they're out with anything, make sure that they are supervised. If it's something that triggers them, whether it be a food, lights, noise, whatever, avoid it. If they don't come in contact with it, seizures will be less. And of course, teaching these parents and the child, if they're old enough, to make sure they take their medicine as they should, and following up doing the drug levels as required and needed. Now, one of the things that I have seen with cerebral palsy is those spastic cerebral palsy children. And they're so tight and they just shake and their muscles like tighten so much and it hurts. Take and make your arm and tense it up. Do that for 3 minutes. You're not going to be able to because it's really painful. So what they have done, and I've seen work, is botulism. Botulism toxin. They give it to these muscles, it relaxes it, and it decreases the amount of spasticity in this child. Now, levodopa, carbidopa is called Cinemet, and it's used for Parkinson's. Now, that spasticity, they're using it in CP children. And it's starting to work because it decreases all of those little involuntary movement, which is called aphatosis. It does help decrease those sort of things. We need to give good skin care. And because the way that they move and they get stiff, you really need good physical therapy, braces. Sometimes they do orthopedic surgery, they release tendons to make sure that we keep this child who becomes an adult has that position in their hands that they can feed themselves or do the things that they can do. So sometimes these kids, now the one little boy I'm thinking about, little Jonathan, when I taught clinicals for Cutler Bay for Fortis, it's this little prescribed pediatric daycare. And little Jonathan, spastic CP. This kid, nonverbal. He couldn't walk. He was in a wheelchair. And his spasticity was so tight with the levodopa, carbidopa, and the botulism. He started to really loosen up a lot. Now, nonverbal, and I could talk to him. Why? He had a little pad that was given to him, and he could push what he wanted or say things to you. That's so important. He's 7 years old, can't communicate. Can you imagine being alert enough to want to and can't? So having that ability is really important. Also, some of these kids are minimally lack of ability to walk. Maybe they have to walk with a walker or braces. These kids need to have something to move around, to get around, to be independent. Very important. They need to be stimulated. I mean, years ago, we didn't. These children, we fed them, we bathed them, we got them out of bed. put them in front of a TV, but we didn't do all of these things. And we've realized that these kids are smart, but we have to give them something that they can learn, right? Like little Jonathan, he was learning colors and he was learning shapes and he was pointing to them. And when he did the wrong one on purpose, he would start giggling, and it was like he had such a personality. So that was stimulating him. He was placed in a regular classroom with other people, and he liked being around other kids and watching it. And when they put on a video that everybody danced, he was trying to clap his hands with it. And it's really important. I mean, let them do as much as they can for themselves. Maybe it's just trying to brush his teeth. And it's not one person. It is speech therapy, occupational therapy, physical therapy, parents, and nurses that all get together to give him care. One of the things about these children, they're impaired, right? But they still have all the needs that a kid, quote, that is normal. They need to be around other kids. They need to be stimulated. They need to be able to be creative. They need to play. So we need to give them things that they can do. So being successful in working with these intellectually impaired, cognitively impaired children, you need to know that these children, you don't need to keep telling them what they cannot do. You need to let them laugh at things that they can do, like Jonathan pushing an oval instead of a circle and then giggling about it. I mean, that is, for him, he felt like a normal kid, right? And that's what we want to do. Another thing about children, autistic, Downs, cognitively impaired, bad behavior should never, ever be accepted, okay? They need to know what they have to do. I worked with a child who was Downs and autistic, and he was 5 years old, and he was bused to this facility, and he would come off the bus that they went and picked him up. He would walk in, he'd have his backpack, take it off, put it in his cubby, sit down, and he'd wait for vital signs. And if he didn't, he had to come back and sit until he did, and then he could go off and play. So anger could be frustrations, the inability to talk, to communicate, but it's sometimes angers because they just want attention. So giving them good attention, not attention to bad behavior. Every child needs an individualized plan of care. And this all needs to be not just nurses and all of the therapists. This is also the family. Family needs support, and they need to know, wow, you're doing really good with him. Or, how are you working with that? And keeping them in part of the team that takes care of them. Some of these kids get to the hospital, they're not in their normal routine. We need, again, what is the normal routine? What can we incorporate into the care to make this kid, continue? Because if you stop for, let's say they're in the hospital a month, they'll go behind, and we don't want to do that. Again, always emphasize the strengths, always talk with that family. And we want to know that these kids, they can succeed. And we need, if they're in school, we need to know, working with the school nurse, and the school nurse working with the child, working with therapists, and it all continues and it's smooth so that everybody's doing the same things. And there's so many support groups out there now. I mean, in the hospital, every different areas, the neuro floor, the cardiac floor, the diabetes floor, all have help groups, families that get together, and it works, and it goes beyond that, state and national. Now, sometimes you have a kid who face looks normal, but they're not. So, and some kids have faces that don't look normal, and they are. Never assume is the purpose of this slide. Find out, sit, talk with them, get on their level, and then find out, do they need any special attention, or do they just need some big tickles? Because they're look, but they are absolutely very much awake, alert, and just quote normal. Now, head injuries. Kids are always falling down, right? They're always, you like to dive bomb toddlers off the couch, on the floor, bang their head on the coffee table on the way. And we know that we need to be watching them really, really closely. We know if they have a concussion, they may have this, for instance, have a kid from a baseball game or a sports event, very common thing that I've seen in the emergency room, that hit their head or ran into something or ran into another kid and passed out for a moment, and then were brought to the emergency room to be checked. Now, this is a kid that you're going to see what we call amnesia or confusion, as in, so was I safe? Did I make it to third base? Or did we win the game? Or is mommy coming? And they'll ask the same question over and over and over again. They're confused, okay? Now, if they get to the point of fractured skull, and there's nothing going on, again, this could be serious too. And that's by monitoring like vital signs, and again, pupils and nursing is the one that do see these things. So to be on top of that. There's one picture down here to the left. You're like, what is this bang here all about? Now, remember, if you're in a car, if you go forward, you bang your head, and what happens? You go backwards when you're done. So you don't always know, is it the front or the back of the head? Where is that injury? And it's going to be those symptoms that you do see. So complications of head injury, we know that if there's swelling, there's going to be some sort of hypoxic episode. Or did they pass out, stop breathing? That causes it too. You're going to have increased intracranial pressure with that cerebral edema. And you will, because of that extra swelling in there, get an infection within a few days of it. So again, monitoring those vital signs. Remember, when you're hypoxic, you know that the brain needs the blood. So they're going to need extra oxygen going to them, okay? We know too much blood flow can cause cerebral edema. So if you have a kid, suspected head injury, and their blood pressure's up because they're in pain, or they're normally up, you need to do something to get it down. Could be as simple as sitting them up. Sitting them up will get that blood pressure down, okay? Because an intracranial pressure that's too high, there's all of this swelling going on. It could cause brain damage, and death could also occur. So signs and symptoms are usually, number one, is that amnesia, asking the same question, dizzy, headache, vomiting, and then, that amnesia. Those are the three big ones. Shaken baby syndrome. Well, I've seen one case of it, and it was actually twins, 3 months old. And the kid came in because the back of the head had some little yellow, green sort of swelling, and the kid was crying. And what the father had done, because mom had to work, and the dad lost his job. So she was working 4 jobs. He got upset because the kids were crying, and he shook the baby and banged him on the surround in a shower. So this kid had, and this is like 3-4 days later, by the color of the bruises, we could tell. And this kid had a fractured skull. He had swelling. He had a hemorrhage going on. And the only thing that we could tell by an infant was the crying, and he vomited. So we knew he had a headache, and we knew something was going on. An older kid is going to be drowsy, sleepy, vision's going to be disturbed. And if it's really bad, this kid, you're not going to be able to wake up. Now, the types of posturing, decorticates to the core, okay? And decerebrate is, down. So core, this is the core. This is the one that comes in. And that's how I've always remembered it. So when you're doing a neurological check, you're checking for increased intracranial pressure, level of consciousness, pupils, vital sign, and their motor activity. And here's a beautiful little picture there telling you that intracranial pressure, that level of consciousness. Remember, vomiting, headache, changes in level of consciousness. Those three things. In infants, you're going to see that little fontanelle big and bulging, and that's showing you that there was swelling. In fact, in that little 3-month-old baby, that's what I saw, that bulging of that fontanelle. So infants, children, what do you look for? Well, looking for pain response. It gets to the point where you pinch the nipples on children or adults, and there's so much brain damage, swelling in there, they only respond like they'll bring their arms up or shoulders up with that pinching. And that is a really severe injury. So that would be a pain response. Level of consciousness. Are they awake and alert? Can you wake them up? Are they moving the way they should? Any posturing, decerebrate, decorticate, pupils, that fontanelle. And in infants, they have these scalp veins right here in front of the ear, and they'll start bulging. And that's the outward pressing on that. And then you're going to see the spasticity of the lower extremities, and you're going to see those morotonic sort of reflexes going on, all part of monitoring neurological status. Now, drowning. Many times a kid gets in a pool or a lake and they're down on the bottom. Somebody will bring them up and then pat them on their back, and pretty quick they come back, right? Now, does that mean the kid's okay? Not at all. If a kid was down and out and under, these children can have up to 72 hours till the onset of any symptoms. So they need to be watched in a hospital under really close observation, and they need a minimum of a sat monitor on to watch it. It causes hypoxia because of the aspiration of water, and of course, usually it's hypothermia because the water isn't body temperature, okay? And if we leave those kids down long enough, we know it's going to have some sort of damage to the central nervous system. So submersion more than 10 minutes, it's going to have severe neurological deficits on these children because of the hypoxia. That's the biggest thing with submersion, hypoxemia. All right, let's go to musculoskeletal next. Well, musculoskeletal is anywhere, in the body, and let's go over some of these things. We know that we need muscles, and muscles move you around, which is all part of it, okay? We know hyperemia is an increased blood flow to different tissues in the body, and that happens for, different reasons. Now, when you're looking at a kid and you want to see, does their muscles and their bones work together the way they should? Well, watching them walk is always number one. If they're limping, something's going on, right? You need to touch it. You need to move it around. Does it hurt when you move it around? You're also going to be checking pulses, the dorsalis pedis, the posterior tibial. Do they have radial, brachial pulses? Are they strong and equal there? If a child is not walking by themselves at 18 months, there's a problem. And this is the child who's going to need follow-up. I've said before, usually at 12 months, kids should take some independent steps by themselves. Many kids are running by them. but many kids aren't. All of my kids, grandkids, they never ever walked at 12 months. Yeah, they tried a step. They ran at 15 months. If they had gone on to 18 months, then we would have gone for more further checkup. The difference between a kid and an adult. Well, let's think about an adult. They've already grown. Their muscles are there, the bones are already there. Kids are growing like crazy. We know the biggest thing that we worry about, especially with breaks, fractures, is the epiphyseal plate. And that's at the end of the bone, and that's where the bone gets bigger. So if we break there, we really probably are going to have surgery, screws and pins, in order for it to keep straight and keep growing the way it should, or you'll have a shorter leg or a shorter arm. So it's basically what you need to know there. So walking. We know toddlers, when they start, they like waddle, right? It's part of what they do. Now, their arms don't swing. If you ever notice yourself walk, your arms walk, right? That's just part of what happens. So 18 months, you get those legs in more and you're stable. As you get older, now you can hop. Your arms are swinging. And then by 6 years, you're about same as an adult. Looking at their muscle tone, looking at, they're doing a neurological examination, you're looking at the movements. Are they equal? Are they limping? Are they able to do the same thing with both arms? Yes, one arm is going to be stronger than the other. I'm right-handed or left-handed, etc. But looking at all of those good little type of reflexes, right? We've gone over some of them: Moro, startle, Palmer, grasps, walking, those necks moving, Babinski, same as adults. Parachute with their arms that come out about 8 months old to protect their heads as they fall. These are all things that we would be looking at. Another thing that we can do, looking at bones and muscles, is of course a simple X-ray all the way up to MRIs and ultrasounds. When we're looking at things that could be a problem, for instance, CBC SED rate is usually looking at some sort of infectious or inflammatory problem. It could be arthritis, juvenile idiopathic arthritis, or rheumatoid arthritis, whatever you want to call it. The JIA is the new name for it. Of course, osteomyelitis. What would you see in a CBC in these? Your white counts would be elevated and the SED rates would be prolonged. And then they're going to do other tests to determine if it is that rheumatoid type thing. But I'm telling you, they still don't know what tests work. It took them 8 years to diagnose me. And all different sort of tests were done. Yes, you're positive. Yes, you're negative. And that it can be in a real frustration, especially with children. So here's a couple of your names and treatments. An arthroscopy, when you look inside a joint. Bone biopsy, when you're looking maybe if there is a cancer. You could have osteosarcoma, which is usually the femur bone, and it will show cancer in there. We use traction, and it strengthens bones, and what it does, it strengthens, separates it, keeps them in position, and prevents muscle spasms. And it really can help in many different cases. And then, of course, if you have a break, sometimes even a bad sprain, they'll cast or they'll splint you. So what happens? You fall down, you have broken your ankle, or you've sprained your ankle really bad. It's the same treatment. Number one, stop. Put your leg up. I mean, in volleyball, go up, spike a ball, come down right on the ankle, and you feel and you're going to be in pain. Put that foot up in the air, rest it, ice it, put an ACE bandage on it, and then you get for your treatment. And that's what can help decrease the swelling in it. So I said contusions are soft injuries are contusions, or sprains, or strains. And the thing is that immediate to decrease that swelling, just like put your leg up right away, right? Another thing with all of these swelling, remember, if you have an ankle that's swelling up, it could occlude blood flow. Always check neurovascular signs. Always check for pulses, okay? That is something that don't take that very softly. You really need to watch it because it could have blood flow. It's not getting there. Prevention injury, well, car seats, we know all about those. Should be at 2 years. You can go front, forward facing, younger than that, rear facing, and in the middle that they want it. Bike, you need a helmet. Pool fences, we've got a lock on the ladder. A little thing comes down. You can't get up there without somebody opening it for you. Window bars or something to keep them locked, deadbolts, and then you have stuff in cabinets that could be dangerous. There should be some sort of lock on them. These are all of the type of fractures that you can have, all for different reasons here. The one spiral, which I don't see it here. Yeah, there it is. That is the one that you worry about. It's like a twist. That's usually your child abuse. So if we see it, we're going to be looking at it. Green stick, one side is broken and the other side is bent, which that right there is a great looking picture of it. Compound is when the bone goes through the skin. Remember, once the bone comes out into the environment, it's infected, could cause osteomyelitis. It needs IV or PO or both antibiotics now. Simple fracture is the normal one. You fall down, you break your wrist, get a cast. Usually 4 weeks for a child to be with a cast. Oblique is when it's an angle across the bone, and then the spiral again is that twisting, again, frequently indicative of child abuse. Many things, these sprains, strains, and contusions, they're like, oh, it's only a sprain. Sometimes it's more painful a sprain than a break. Today, they're putting them more in casts and splints because they have found that this helps it heal a lot better, okay? Sprain is like me playing volleyball and it ripped, the ankles out. I can't tell you how many times. Strain is when you do something on the same muscle over and over and over and over again, and it causes it to be swollen and painful. And a contusion is a bruise of some sort. Remember, it could be just a contusion. Always check neurovasculars, blood flow, and pulses. Fracture, you're going to see a kid, they're going to complain of pain. They're going to be holding their arm. It's going to be swollen, painful to touch, can't move it. Part of what a fracture is. Children heal really quick, like I said. I mean, usually 4 weeks, they're in and out with it on. So care of a kid, well, it could be traction. Traction, as I said, we use this a lot for fractured femurs. And why a fractured femur traction? Well, there's something called Buck's traction. And it goes to the boot. It's like a boot on the foot. And it's like tightened just on the skin. No, nothing goes into the muscles or skin or bones. And it pulls because the rope goes up over a pulley and there's a weight. And it pulls that fractured femur so that the ends are together. And it's not to heal it, it's to give you time to get the surgery you need. Because usually it's going to be a day or two before you do surgery because there's so much swelling going on. And it prevents those muscle spasms, the little pieces of bone going into the muscles and nerves, and it hurts, okay? With the care of it, you're always checking the weights, making sure they're free hanging. Make sure the foot's not on the end of the bed. You can help pull that child up in bed off of the end so that that pull continues so that you're not going to have that pain. So here's Bryant's traction that can be used for hip dysplasia. And they're saying that a child should weigh less than 15 to 18 kilograms. Otherwise, it's not going to work. Okay. And sometimes they use that also for fractured femurs. Buck's traction or Bryant's traction. Again, making sure the weights are hanging freely. I've mentioned it a couple times already, but again, Buck's traction, it pulls it. There's a picture of it to give you some ideas, making sure that it's held, that it's free hanging, nothing's holding it. Very important. Now, you have usually in Buck's traction a fractured femur. There's a lot of swelling that goes on before even medical care can be given. Again, check pulses. That swelling could swell so much that it occludes blood flow. And you'll be checking pulses every time you do vital signs. Every 4 hours, I would do it at the normal on it. And if you see that leg not as pink, can't move it, decrease pulses, you call that doctor immediately because there's something going on. Russell traction, similar, absolute similar. Same thing as Buck's with the care of, but it has an extra little pull around the knee. It's the only difference. Why would you use one or the other? It's a physician's choice. So again, children in traction, make sure the body's in alignment. The head of the bed can't be elevated because you're not pulling. So just up a little bit. Heels should be up, away from the end of the bed. That leg, that is good. Make sure you're wiggling the toes. Make sure you're preventing blood clots, right? Anti-embolism stockings, AE hose, neurovascular checks. Make sure you're checking for skin because it could be rubbing, causing breakdown, and medication for pain. These kids hurt. Fractured femur, they need an opioid. It hurts. And because you're giving these opioids, make sure you're giving something to help them move their bowels because they will get constipated and then you'll have other problems. And they do use these overhead little, what they call a trapeze, and these children can by themselves lift a little bit, gives them a little bit of freedom. As I said, weights are hanging freely. Don't let anybody touch them. Don't put them on anything. They should always be there. It's not 23 hours a day. It's 24 hours a day. Keep it pulling so that that bone keeps the way it should, prevents all of the pain, the muscle spasms, etc. Okay? 5 P's, always check. Pain, pulse, pallor, paresthesia, movement, paralysis, numbing, all of those things. Anything that is more than normal, call the doctor. Skeletal traction can be used also, and this is more like with right in like into the scalp for scalp traction. And these things are used for different things, usually neck injuries, okay? Again, we're doing all of the same things, checking neurovascular. I think you've seen it 3 times now. Neurovascular checks are very important, making sure that there is blood flow going to where it needs to go. Now, this is an external fixation device. It's the other name for it. And this is for a fractured bone in the bottom. Sometimes they use this when we want to lengthen. One leg is shorter than the other. They'll put these things on to get those legs the same. But remember, these are little pins going into the bones. They need meticulous skin care, pin care, okay? And looking for Does the kid have a fever? Is it red? Is it swollen? Is there, any sort of drainage going on, or is it hurting? Those things we would be reporting. Most of the time you're going to see is staph. Staph is the big one. And then we know staph in bones is dangerous and again causes osteomyelitis. How are we going to see? What does it look like? How bad is it? Well, what did I say we do for infections or inflammation? White count, right? And your SED rate. We can look at x-rays. We may or may not see if there's an infection on that, but they do say bone scans are more reliable. It's more of a nuclear test that they do, and they can see hot spots, as they call them. As I said, osteomyelitis, it is a very, very hard to cure. So it is several weeks of IV antibiotics. Remember, these IV antibiotics are dangerous. So we need to have good nutrition, plenty fluids. They need to be monitored, their blood testing to be sure that they're not getting too much. And remember the taking care of the pain, again, and you're going to distract them. If they're home in bed or in the hospital in a bed and they're on a long-term treatment, remember, you got to do something to keep their brains going. Casts and splints. Well, you'd be surprised. Casts go on and no big deal, right? Well, I've seen them come in and, all of a sudden their hands are swollen, they can't move their fingers, and the pain is bad. What it is, all the swelling, they didn't elevate it. They didn't put ice on it. They didn't wiggle their fingers like we have told them to do. And it could cause what we call compartment syndrome. They need to get to the doctor or to the emergency room so they could either remove it or put holes in it to decrease the pressure so we get blood flowing going in there. You can lose arms and legs and toes and fingers with no blood flow, right? And if you look, that leg, if it's a cast, the other leg, because it works so much, you might see the legs difference in size when we are done with this whole casting. So again, elevated on a pillow, checking neurovasculars, teaching parents and children to check, keep it moving, and then if they can get up out of bed, teaching them. Actually, if they're going home, I want them to show me how they're using those crutches. Not every kid can do that. Now, a muscular dystrophy that you do see. Duchenne muscular dystrophy, and there's many different types. They picked this one, and I'm telling you, it's on Hesse's, it's on your NCLEX. They just love Duchenne. And all it is a progressive muscle degeneration. And it is usually males, usually about ages 2 to 3 to about 6. They'll be up, they'll be walking, they'll have that funny waddling gait, but they never get better and start falling down more. These children usually are cognitively delayed also. So these children need some good physical therapy, etc. These are all the symptoms you see, but what you need to know is this is a kid who started to walk and now is falling. You're going to see them, and this is what I do all the time, a Gower sign. I get on the floor, I need to get up. I take my hands and I walk up my legs to get myself up when I'm done, right? That's Gower sign. And it's because their muscles are so weak. These children, because they're not moving as much, they are overweight, they're cognitively delayed, they need intensive physical therapy, and many of them, do end up in wheelchairs because their muscles get so weak. Now, your heart's a muscle, so is your diaphragm. So usually about in the adolescence, these children do die. So it's that progressive thing that goes on. And if this child is alert enough, they really will get depressed. And if they're with other kids, they want to do what other kids do. So we need to encourage them with other activities that they can. Coxa vara is when the hip comes out of joint. And this is usually at that stage in the beginning of adolescence where they have that big growth spurt. They grow 20 to 25% of their height and it slips. And what we do is we do it more medically, if at all possible. They'll put them on that buck traction, which pulls it, puts them into shape, puts them on bed rest, gives them NSAIDs for pain. Usually that will help. Sometimes they've got to go to the point where they're going to need surgery to fix it and put it back. Leg, calf, birth. This is the hip joint again. But for some reason, there's no infection. All of a sudden, blood supply stops going to the head of that bone, the femur bone. And what you see is a child all of a sudden starts complaining of pain and limps. More common in boys, ages 5 to 12, and it takes a while for it to heal. Usually, again, this is a child who could be placed in buck traction to release the pressure. Go tell Pop. That's my grandson. So usually with this, we put them on buck traction, give them NSAIDs, and it takes a while for it to get healed, and it is quite uncomfortable. You usually will see this fuzzy area on the femoral head, and that's showing you that there is some sort of infection going on there. A lot of times it does, the whole hip needs to be replaced eventually. Not all the time, but some do. I've mentioned osteosarcoma already. I said, okay. All right, don't answer the door. Did you open it? All right, leave it alone. Close the door, you're safe. Good boy. Open the door, front door. All right, osteosarcoma, I've mentioned it. It's, as I said, adolescence. What happens is the femur bone, usually, it says long bones, but femur bone, all of a sudden they'll be complaining of pain. And they'll see the swelling and the pain getting worse. They do an x-ray and they'll see it. And there's a big worry about metastasizing. If we don't catch it quick enough, it could go to the lungs. And they're also saying if they've had a retinoblastoma, they're at higher risk for it. And what they do with it is they'll either take off the entire leg, or actually what they do is they take the lower leg and attach it up where the upper leg was. Okay? And what they do that for, and it's a huge surgery, but it gives the body somewhere that they could put a prosthesis so they could walk around. Can you imagine having it on your leg backwards, but that's where we can put a prosthesis, okay? Ewing sarcoma. This is the marrow of the long bones. Again, this is a really, if it's already metastasized, your prognosis is pretty poor. Again, bones go to lungs, try radiation, chemo to try to get rid of it. Sometimes it's in the scapula. You can imagine clavicles can be anywhere. So depending on where it is, if they can get rid of it. JIA, I've sort of gone over it. We know this is where the body attacks its joints. It says, joints, I don't like you, let me go in there. It is an autoimmune disease, and there's no cure. And you see this, no specific tests. What you do is to try to keep the pain down and try to decrease the body's response to joints so that it will not, attack it. I mean, NSAIDs is a great pain medicine. And the biggest thing with JIA is to keep them moving. These children will have a hard time with morning stiffness because you've laid there. You haven't moved. You get up, you try to move, and your muscles hurt. Therefore, you'll have difficulty walking. You will limp. And of course, there is swelling in the joints. One of the things is uveitis. The eyes will get all reddened. That's why these children, even adults, need to have frequent, at least yearly eye exams. There, as I said, there is either more than one or there's more than 4 or less than 4 joints. It depends. All kids, all people are different with this one. What we usually see with these children is all of a sudden they're limping or complaining of pain. They're complaining of a joint hurting, and you might see this really like this rash. Where did it come from? You might see these fevers, and then they'll go through and do all of the inflammatory factors, the SED rate, the C-reactive protein, and they do look at white cells also for this one too. As I said, there could be more than polyarthritic or, less than. So again, red, swollen, painful, tender. A lot of times you'll see these in girls in their adolescence, although you can see them a lot younger. And this is that 4 or fewer joints are your younger ones. Again, it's just the pain, the swelling of the joints. So what is your goal? Well, number one, you want to maintain function. And that is done by exercise. For me, it's the swimming pool. Great place. Keeps my joints moving. Children, it's whatever keeps them moving. Could it be out, doing exercise in the gym? Whatever it is, whatever they want to do, as long as they're moving. So we want to preserve the joint. We want to make sure that they grow properly and that they still keep independent. And because it is lifelong, the family and the child both have to learn how to work with it. The kid really needs to know what's going on and what he needs to do. I mean, when it gets to the point where he hurts, he needs to tell mom, hey, I'm really hurting. And these kids usually do have either weekly injections, or there are some pills now that can be taken in order to try to decrease, the body from attacking. Sternocleidomastoid, a torticollis. A lot of kids are born like that, right? Because they're pulling their heads on the way out, and you'll see them twisted. And it usually, that's what you see. I mean, a lot of times you don't see it as a chronic sort of things, but sometimes you're going to see the neck also with the hip dysplasia too, which can happen. So what do we do? Physical therapy. Heat is a lot of things that we do on these children, and just keep them moving. And then if they're always looking to the right, we'll turn them so they have to look with their left. Literally, you're just trying to make them move that joint, and it takes a while to get it down, the inflammation down, but it can be cured. Now, scoliosis. This is a lot that you see. Could be due to poor posture, but a lot of times it's more common in your girls. A lot of times we are going to see this in that pre-adolescent growth spurt, where all of a sudden they have this S-shaped curvature to their spine. You're going to see that one shoulder higher and one arm is longer because of the way that they stand. And if they bend over, you're going to see that S shape. So what do we do? Well, scoliosis, unless it's severe, which is greater than a 40-degree curvature, that requires surgery. Under that, it is putting them in these braces 23 hours a day and put a t-shirt underneath because they do sweat. Be careful with skincare. And then they're given physical therapy for strengthening their muscles in their back. And they usually do really well with just that. We know kids are always up out doing something, sports injuries. They don't work out the way they should. They run into somebody, a cleat gets them and they're cut. I mean, this is all part of common injuries that can occur. We expect it if the kid's out there playing, especially sports. We just have to be prepared for it, right? Which sports are more? Well, gymnastics. That would be your strain, right? Doing the same thing over again. Wrestling, you're pulling and stretching. Football, soccer, I can't tell you, I had a big toe, a little toe that was disjointed, kicked somebody in the shin and a toe dislocated. Very common type things. Hockey, basketball, volleyball, anything. Skiing, ripping my knee out skiing. I mean, these are things that happen with children. Now, we don't like to talk about it, but there are some families, and it's, violence, whether it's with mom and dad or with the children, or everyone. It's just, it can affect any child in any social class. What are things that usually are those things that put little, red lights and bells go off? Oh, okay. Well, if you see a kid who is from a family where there is a lot of financial difficulty, you're going to see more possibilities. You're going to see if a family is in using substance, whether alcohol or drugs, whether you have a family who has been abused as children. All of these things can lead to child abuse. Now, there's all sorts of abuse. There's an emotional abuse or neglect, sexual abuse, physical neglect or abuse. Any of these things can make a child not feel well. If you're always told that you're stupid, you're ugly, you're fat, you're whatever, I mean, and you never get praise from mom and dad, I mean, this can really affect a child as they go on. If it's sexual abuse, we know that that can affect them and they don't know who they can talk to. And physical neglect, they don't have a coat and it's cold outside. They don't have a home to live in, and they are living in a tent somewhere. And this happens, and I've seen it. And of course, physical abuse, like that little boy, that little 3-month-old, the father with that shaken baby just cracked his head against, the shower. These things happen. And as a nurse, you need to be aware. And what do? Is we're going to make sure that we report it to whom we should. As nurses, I'm going to tell my charge nurse, I'm going to tell a physician, and they're going to make sure that if it's police, we get the police in. If there's guns and what involved, we're going to get, DCF, whatever, just to make sure these kids are safe. And it is the hospital's responsibility. If we're suspecting, we're not letting that kid go home until it's been evaluated. So anybody can report abuse to Child Protective Services. And they have to have a visit to that home within 2 days or 3 days. And at least that this child, that you've done what you can do to help them. Now, there's ways to look at child abuse, and it's looking at, for instance, any marks on them. It could be also their weight, if they're too skinny, right? Or dirty clothes, a lot of different things that can say, well, there's something not right here. Now, remember I said that that kid who had that bruise between his head, that 3-month-old, and we knew it happened several days earlier? It's because he had green, purplish looking stuff, the coloration behind the ear. So we knew it was almost a week ago that that had happened. So knowing red or purple, 0 to 5 days, 5 to 7, green, 7 to 10 is yellow, and then it gets to the point where it's brown. So we know about when it happened. Now, be careful with cultural things. You know, think about the Oriental, right? They do this cupping thing, which looks like bruises, which could be on the back or arms or things. Be aware of that, because not all marks that look like could be don't mean that they are. It could be cultural, so remember that, okay? Because it's sometimes could be misinterpreted, and we don't want somebody who's doing good for their child, you know, to be questioned. And that's all we got for today. How'd you all do? It's a long PowerPoint, a lot of information. You have any questions? I'll be sending you the Cahoots. Make sure you go over that, okay? A lot of great information in there, a lot of concepts that you need to know. Remember, I do have my reviews already posted. If you need anything, even though you're in the other class, remember, I'm still here. I don't go away, all right? You guys have a great evening. Have a good weekend. My pleasure.
Ms. Bogart, can I talk to you after everybody leaves?
Sure.
Thank you, Professor.